So this is our vision, mission, and values. And just before we even go any further, we just want to at least share this with everyone. This is something that our sports medicine team put together. And it's something that's really important to us. And whenever we're looking at people, either for interning or for positions or whatever it is, we want to see if they hold that same vision, mission, and values we do. So if anyone's interested in sports, or more specifically baseball and working for us, these are the things that we hold very important to us. We just wanted to share it all with you today. Your turn, right?
No, it's your turn.
No, but we said we're going this slide, then you go. Remember?
No. Yesterday when we practiced, you said you're going to go first and then me.
No, but don't talk to me around.
Don't talk to me around.
Remember, we were talking about.
I know I'm just a meathead.
I know I'm just a meathead.
I'm going to go through the vision, mission, values, and then I was like, you're going to go from there.
That is not what we planned, but we'll just go with it.
All right, whatever.
Bottom line up front, guys. We're talking about a repair. And anytime that you have a repair done on our body, we have to take into account for the biological process of healing, right? And a lot of times with that, what happens is there's an increased immobilization period, as well as an increased risk of atrophy, strength loss, as well as a limited range of motion. All right. So what you just saw was the opposite of working together and collaborative and being on the same page. It is imperative that we work together because when we don't, what happens is the athlete suffers because they're the most important part of this process. It doesn't matter how many letters he has after his name or titles before it. Myself also, the athlete is the most important. When I first got going into this, I always thought, when I think about rehab, I think, well, all right, the PT and the AT and those guys, they have it when the athlete has pain, right? And then once the pain is gone, they're just passed on over to me. Now my job is to get them strong. Well, that's far from the truth nowadays. And you guys would probably in your environment see the same thing. You know, we work hand in hand all the way through the process. And what we have to take into consideration, though, as we go through the presentation today, is that every athlete's going to be different. What you're going to see today is just a foundation, just kind of a blueprint as to what the protocols will look like. But we also got to remember, and we're going to remind you throughout the day that it's athlete specific. You can progress, you can regress, but those progressions and regressions are based on what that athlete needs.
This is another just going off example of how important communication is. This is something that we talk about a lot. It's just the big rocks. And so what we think is important, obviously you need to know the details and you need to respect everything that's important, whether it's like very specific or not, but the most important thing is you have the big rocks down. And so that's kind of what we want to go through in this presentation, because we don't want to go through every little detail of this rehab process. That right there could be a 5-6 hour presentation right there. What we want to do is give you the big rocks of what it's going to be like for us and what are the most important things that need to be accomplished through the rehab process. So I have a question actually. How many postoperative elbows has anyone treated here? How many?
Like UCLs?
Yeah. Okay, perfect. That's why I want to use that example, because before I was here with the Diamondbacks, I treated one. And so it's one of those things that you don't see very often unless you're seeing baseball players on a day in and day out basis. And that's one of the things why we want to make sure that we talk about what's the most important thing throughout this rehab process, because I treat them all the time now, but before I did, I had no idea what I was doing. And I was trying to figure it out and pick things up as I go. And a lot of the times now it's a lot of leaning, especially early on, I was leaning on my teammates a lot. And now I feel like I'm at a good point or a good spot because I've gotten so much experience, so I'm able to treat a lot more. But I want to use that as an example because unless you're around it a lot, you don't see it very often.
So our objectives today is we're going to start with an athlete getting hurt, right? Elbow issue. All right, so we're going to go through the evaluation process, what that looks like. So you have an athlete, boom, elbow hurts. He's evaluated, now he needs surgery. We're going to talk about two different types of surgeries that we have to repair an elbow, which will be Tommy John, as well as an internal brace. From there, we're going to go into pretty much a step-by-step guide or basic goals overview of what each phase. We have 3 different phases, starting off with post-op week 1 and going all the way up to 52, which will be the 3rd and final phase. So what our goals are with this is to just kind of give you the foundation, as we just said, but I want you to remember that is all athlete specific, that you can progress, regress based on what the athlete needs.
Off of that point here too, everything is guidelines. Nothing is set in stone and nothing is going to be exactly the same for every athlete here. We just want to give the biggest guidelines that you're going to see. We're just going to go briefly through the evaluation. Obviously, there's a lot more that's included. We just want to mention some of the highlights and some pearls that we've kind of learned along the way. Medial elbow pain is obviously a big one. I wanted to put felt a pop up there because I'll be honest, that's not usually the case. You're going to see that a lot, maybe when you're watching games on TV or something and a guy throws a ball, immediately grab their elbow and they felt a pop. I'd say half the time that's the case, but it's not every time. A lot of the times there's a lot of other things that happen. So I wouldn't get so caught up in, hey, I felt a pop, this is what's wrong. It's just one of the many circumstances that you could run into. I like looking at some of the other ones. Like, you're going to hear a lot of random things. It might be, it just doesn't feel right. It feels tight, or the arm feels dead. It's important for us when we're going through some type of subjective eval to get as much information as possible, because it's not always going to be that acute injury on that one throw. I felt this one pop. Moving into some of the objective information off of that. So they might have limited range of motion. I want to bring this one up because anytime they might not have felt a pop, but we had an athlete who threw a bullpen, felt great. He woke up the next day and he just couldn't move his elbow. It was just stuck in basically a spot of almost 90, 100 degrees of flexion right there. And so for us, it was one of those, something's guarding for some reason right here. So something happened to his body. We aren't sure what, but he's guarding. And so his motion's limited. He felt no pop. He threw a bullpen just fine. He threw more actually at a higher velocity than he had in the previous bullpen. And he maintained that throughout the whole bullpen. So I think it's important. You're going to see a lot of different presentations. And then I want to just put, he may have pain over the medial elbow. It's not every time I have pain right here. Sometimes it's just, I don't know, it just doesn't feel right. Going to some of the testing and assessment, I'm not going to spend too much time going over these two right here. The valgus stress tests and milking maneuver are just some special tests that are common that are used throughout the baseball athlete. But the ones that I want to talk about more pearls are actually overpressure reflection. So when we're going through our assessment, we're going into range of motion. We put an athlete into flexion. We like to apply some type of overpressure into that elbow. And what we're doing in that elbow then is we're going to be gapping the humeral ulnar joint right here. Because we're providing that flexion, it's going to gap a little bit. What that's going to do is just put a little tension on the UCL. A lot of guys who have some type of UCL involvement, that doesn't feel very good for them. So that's one thing we like to do because it gives us a better idea of, all right, that doesn't feel good. We need to look more into this. And that's where I get into the second point, the sublime tubercle right there. Can everyone see this right here? Tried to make it. Okay, cool. So what I did is just drew a line, and literally early on, I would just draw a line on that athlete. I'd go from the medial epicondyle and just go distally from there. And I just draw that line straight through. And what I'm doing during my palpation assessment is, if I'm pointing and palpating above that line, most of the time we're going to be on more of a flexor mass and more flexor muscles. When I go below that line a little more, and obviously this isn't set in stone 100% of the time, I also want to say that, but once we get below that line and palpate, usually around the area of the sublime tubercle, which is where the UCL attaches. So if you're palpating around there, I just kind of like using it as a baseline, like, hey, if I'm palpating lower and I feel, or they feel more discomfort, and that's kind of the pain that they have, that's more of an indication in my head of, okay, this might be more UCL involvement and less flexor problem. And then if all of those things are going on, everything's happening, what's going to happen next is most likely they're going to have some type of surgery. And we're going to spend a lot of time now, because this is what we get asked all the time. If it's like, hey, we're going to have surgery, this is happening a lot more. It's, what surgery am I getting? What do I get? And it's really, really dependent on what's going on in that elbow and that athlete.
You got to also make sure that there's so many people collaborating with that athlete. When that athlete asks that question, there's going to be multiple doctors involved. At the pro level, you're going to have their agents involved, and everybody has to be on the same page to determine which surgery they're going to get.
And honestly, it's okay if right after this happens to say, I don't know, I'm not sure. We need more information. I don't know the answer right now. So Tommy John surgery, what it is ulnar collateral ligament reconstruction. It's a lot easier to say Tommy John, so we're just going to call it Tommy John from here on out. Usually for that surgery, you're going to use either a forearm muscle, which is the palmaris longus, or if not, you're going to use the hamstring muscle, the semitendinosus tendon. And so a lot of times too, I've asked like, well, which one do you want to use? Do you want to use the throwing arm? Do you want to use the non-throwing arm? And it really depends. I've asked a couple doctors. They say whatever one's the biggest one. They just want to take, if you have the palmaris longus, whichever one's bigger, we're going to take that one. It doesn't really matter what side you're taking that from. And then the two most common methods for surgery, I'm not going to spend a ton of time, but I do want to mention, at least highlight one thing with both of them. So the two are the modified Job procedure and then the docking technique. And going to the modified Job, this is the one that we normally see, and I'd say it's probably the most popular one. What it is they figure eight the tendon and they attach that tendon to itself. So they drill holes into the arm and then they figure eight that tendon so that tendon is now attached to itself and it's able to freely move through the holes that are created in the arm. The biggest difference between this one and then the docking procedure happens to do with what they do with that tendon. So in this example for the graft, what they're doing is actually docking it to the back of the humerus. So the bigger thing with this is those sutures are very fragile and very sensitive early on with how they've docked it. So what we had happen with one of our surgeons was he didn't want to push too far into flexion too early on to have that graft of those sutures pull apart there. So that was probably the biggest difference between the two. The docking technique, we had to be a little more cautious with getting into flexion compared to the modified Job. So it's just important to respect the procedures and what's going into them. The newest one is the internal brace, and I'd say this is probably the most, I'd say it's getting more and more popular because there's a lot more going on and we're learning a lot more about this. The easiest way to think about this is used for a UCL repair and not usually for a reconstruction, but what it is material that you're going to put that is basically very high tensile strength suture that's going over top of that elbow joint right there. And the easiest example I can think of is the material that's used is similar to what was used with Tua Tagovailoa a few years ago with Alabama.
Roll Tide.
And what happened? And so what happened with him is that he had a severely sprained ankle during the season. Originally, he was going to miss anywhere from 8 to 10 weeks. They actually performed a procedure and used the same type of material on his ankle, and they call it a tightrope procedure. And he was able to return in 3.5 to 4 weeks. So the recovery time is significantly faster than what it is for something else. And then going in a little more detail at the internal brace. So what we have here, usually when we repair the UCL or reconstruct the UCL, the anterior bundle is the most important thing that is getting reconstructed and repaired. What we found out, there's actually two bands to that anterior bundle. There's the anterior band and the posterior band. So what the internal brace is basically there to supplement is more of the posterior band structure and the stability. So they found out that as you get into higher levels of elbow flexion, the posterior band actually provides more valgus stress than the anterior band. So when we're talking about baseball players who spend all their time in about 90 degrees of elbow flexion, it's important that they have a lot of stability in that elbow. And they found that, hey, let's just put that brace right there, and that'll be the posterior band. The UCL repair will act more of as like the anterior band. And some indications for it, I think it's one of those things where people are like, that sounds pretty awesome. Why doesn't everyone just get that then? So it's always used usually with a UCL repair. But when you repair the UCL, not every player can repair that UCL. It's indicated for people who can get that UCL repaired. And so the best example I have from this year is we had a player who was getting Tommy John, and he asked the doctor, he said, well, can I get the internal brace, you think? What do you think? What do you got on this? And the doctor was like, well, I'll be honest, I describe your ligament to someone as shredded. And so because of that, I can't repair this ligament. It's completely torn apart. And so that's why in star right there, it says with good quality tissue. So it needs to be someone who has more of that acute felta pop. This happened in one instance, and the tissue is still in good shape. That's why avulsions are good for it, because that UCL is still intact and they can just kind of pin that UCL down and then put the brace over top of it. But the most important thing is someone who has chronic changes in that ligament over years and years, they're not going to be someone who's most likely indicated for the internal brace. And then these are pros compared to UCL reconstruction. This is pretty important, especially in the rehab process. So early on, you can do a lot more with the internal brace than you can with Tommy John, which is really interesting because it provides so much support and so much valgus stability. You're able to protect that healing ligament early in rehabilitation. And because of that, you can accelerate that return to play significantly faster. And so it's very well protected there. And as some of this research shows, it has greater resistance to gapping, greater under fatigue, and then a greater load to failure rate. So especially when you get into those higher angles of elbow flexion. So when compared to UCL reconstruction, you're able to push things a lot faster because you have so much more stability early on in that elbow.
So what we've done is we've kind of put them side by side and created two documents really to show the differences between the two. So you have Tommy John on your left and you have the internal brace on your right. The highlighted areas that are blue and red are the differences. But what I want to take your attention to is how much quicker it's a return to play weeks 8 through 10. And we're down here at weeks 20 to 22, or not return to play, but with no limitations, just being get to the throwing point. Sorry for the throwing program. So look, it's way quicker is the main difference. So we're going to focus on this today, and we're going to take you up, like we've already mentioned, we're going to take you up for post-op day 1, week 1, and work all the way up until that player's back on the mound in full competition. So first thing we have is the post-op phase 1. We're looking at weeks 1 through 6, and our goals for weeks 1 through 2 are going to be to protect the healing process. Just got done with the surgery, got to make sure that athlete is immobilized, he's not doing too much, decrease the pain and inflammation, as well as remove the stitches. Now, from a performance standpoint, I turn into a mental skills coach. As someone that has had way too many orthopedic surgeries on their body, I know how quick and how important those first 3 weeks are to keep that athlete from falling into depression. All right, you take a guy or a girl or anyone that's had this surgery, and they go from having a very regimented, strict, routine-oriented day that starts out in the morning, going all the way to 11 or 12 o'clock when that game is over with. You take them and you shut them down. You put them in a jail. You send them back to our training facility where their team is out on the road still competing to try to win a championship. All that stuff plays a role on that athlete's mind. So we had the guy that Merritt mentioned earlier that had his was shredded. He came in this year, one of the hardest workers we have in our organization. He comes in, and the very first thing that I said to him was, "How's your coconut, man? How's your brain? How's your head? Where's your head at? How are you doing?" Also, if you don't have those relationships with that athlete or that patient, now's the time to start building them.
Going to some of the contraindications, just so things to be aware of and things that, hey, let's not mess this up early on. The biggest thing, we're progressing range of motion to tolerance. This isn't just elbow range of motion, we're also talking wrist. This is what this picture is right here. It's kind of hard to see here, but all those circles are different scars that he has. That's where they took the graph from. So that's in his throwing wrist right there. So it's not just the elbow that we need to worry about. There's a lot of scars in his wrist, and I'll be honest, after surgery, these are more painful for guys than that elbow. And these are the ones that bug them even more. So it's important that we get that wrist moving because we got to get out some of that swelling. And at the same time, though, you can't push it too far because you don't want to tear open those stitches. And then when those stitches do come out, what's going to happen is that thing's going to scar over and it's going to tighten and get very hard. You need to make sure that you do a lot of scar mobility on this because all you're going to do is limit his motion if you avoid this. So it's one of those things that we've definitely learned along the way. It's really important. Other than that, avoiding IR, ER isometrics. We don't want to put any type of valgus stress on there. So we just need to let it kind of sit, respect biological healing, like Dave said before. And then there's no sweating for the first 2 weeks. For us, the big reason for that is just because we don't want any type of infection to happen in the elbow. It's just not worth it at this time. So if they can't sweat for 2 weeks, like Dave said, they can't do a whole lot. And you're talking about a guy who was competing day in and day out, and he's trying to move through the ranks and get to the big leagues. He can't even sweat now. So it's really important that we're not really just thinking about his elbow. We're just thinking about him and how's he doing? How's he feeling? Because it's a lot to take in. And these things happen fast where he might blow out his elbow in, let's call it Wednesday. He's here Thursday in Arizona. He has an MRI and he's scheduled for surgery Friday or Monday. So they don't even have time to process sometimes with how quickly these things happen. So it's important that we take time for them here to let them process and understand what's going on.
So we move into the 3rd through 6th week, still in phase 1, still in weeks 1 through 6. Now we can start biking. from a strength and conditioning / performance standpoint, you know, my first thought is now this guy's going to, the detraining's coming, you know, he's going to get out of shape. His how can I keep just as much strength in his legs as I possibly can. So we can actually start doing some lower body lifting. This is going to be no hands, so no intensity at all, meaning holding any weights or anything, even non-injury side, no hands whatsoever. What we like to do is we use a weighted vest. If you have a weighted vest, make sure that someone puts that weighted vest on the athlete and he does not put the weighted vest on himself or herself. We're going to begin progressing the wrist and elbow range of motion, light forearm and shoulder strengthening, as well as shoulder stability exercises. Merritt and I are going to demonstrate. The first thing we're going to do is demonstrate our arm care / shoulder strengthening exercise. Now, this is going to be a progression from the manual. We want to start out with doing manuals, which basically, so we'll start here. Put the ball between his knees, heels, bring his toes up just a little bit. He'll bring his pelvis up just a little bit so that it gets in a neutral position. So we'll start doing a manual technique where we can just gauge how much strength that he actually has in his shoulder. So I call this one just pull the sword. So he'll put his thumb in his pocket on his opposite hand and he'll take it straight back. And then once he gets there, he'll bring it back to me. And I can just gauge how strong that he is in that shoulder. We'll progress it from there. We'll progress it to there to light tubing. And here I'll go over a couple of the other movements with this, but he'll start off with the same one. Just pull the sword, thumb in pocket, take it over to hitchhike. Here we'll go 10 to 12 reps on that. Then we'll take his shoulder straight up. And all we're going to do is have him abduct his arm and not come back, adduct it any further than where my hand is. All right, so we'll go here, another 10 to 12. So now the next one is the A. So I just work my way around at an angle. He'll take it straight down to his side, palm facing me all the time. The next one, we're going to switch. So that was Merritt's left arm, but for demonstration purposes, we're going to switch arms and put it on his right, let him use his right arm. So here we're going to take the towel, put it under. What we want is the shoulder and the elbow to be in a line. If I don't, then I take it out, and when he starts externally rotating his arm or his shoulder, he's going to get more deltoid, and we want to make sure that we're focusing in on his rotator cuff. So here, this one will be manual. So all he's going to do is he's going to externally rotate to neutral. That's it, no further. And here again, it'll be 10 to 12 repetitions. We'll probably do that every day to every other day at the athlete's as much as the athlete can stand.
A big reason for us doing manual too is because we get a good feel for what their strength is like throughout that process. So it's not just, all right, let's give you some weights. Oh, let's move up to the next pound of weights. Let's mix things up with them and switch it up so that we can get a feel what their strength is and then adjust accordingly. So the last one here, it says shoulder stability exercise above the elbow. This is something a lot of people do, some type of rhythmic stability where we're going around like this. When we have someone this early on out of a UCL surgery, we don't want them to be right here because all I'm going to do potentially is put that valgus stress into that elbow. So what I mean is we're just going right above the elbow here. So we're able to get some type of rotator cuff involvement and some type of stability without putting any stress on that elbow. And if we're not sure, we're like, oh, maybe that'll put some stress. We can keep the brace on with them for this too. It's not a big deal. We're going right above that elbow anyways. We're not going to put any stress on that UCL at that time.
Here you have a washed up JUCO athlete showing a little exercise with the weighted vest. This worked pretty well this summer with some guys that was going through the reconditioning process. Just threw the weighted vest on, ever how many squats you want, have a walk and lunge it forward, distance, whatever you want, have them squat again, and then reverse lunge back. Obviously, there's a lot of sagittal plane there, and that's okay. We can get the frontal plane inside the weight room, which I'll show some of that here in a few minutes. But just straight back, and then have them do. You control the resting in between the sets. You can get a little bit of a metabolic effect based on how much rest you give them, how fast you want them to go. You kind of control the variables there. It goes back to just knowing your athlete. All right, now we're moving into phase 2. Phase 2 is our pre-throwing phase. All right, so now we're prepping these guys to get them back to actually throwing a baseball again. So here, this is going to go week 7 through 22. So now the brace is coming off on week 6. We're going to increase the shoulder and scap strengthening, and then they're going to be able to get up on that elliptical machine or that treadmill and start pushing their cardiac output a little bit. We're going to initiate the valgus stress, and then we're going to continue to increase that forearm. That forearm is something that some people kind of overlook when we're reconditioning or rehabbing injuries, because you're thinking about the shoulder and all, but that forearm is very, very important in throwing mechanics. So we're going to demonstrate what we do from a forearm standpoint a little bit. So we just have a tiger tail. So I'm going to put it in the athlete's hand, and I'm just going to gently push down a little bit, and he's just going to flex his wrist. Again, we'll go 10 to 12 reps. I'll ask him then to stay up in a flex position and as tight as he possibly can, and I'll force him down a little bit to get a little bit of the eccentric. So then we'll flip over. I'll have him extend his wrist. Again, just putting down just a little bit of pressure. 10 to 12, we'll have him stay in a locked or a flex position. There. Then we'll go here and hold it at the bottom, and we'll go ulnar deviation. So he'll pronation. And then I'll have him stay in a pronated spot, and I'll work him back up to get the eccentric. Then we'll go in a supinated, again, pushing a little bit. Then I'll have him stay in a supinated position and work the eccentric. All right, then we'll go into the flexors. Again, I'll have him hold it here, and I'll pull out. Then we'll turn it over. Extensors. And then I'll have him stay in an extended spot and push it in. And I'll have him spread his fingers out, and we'll work the intrinsic hand muscles just by bringing his fingers together, skipping them, just telling him to keep them out and not let me bring his fingers together.
Big reason we wanted to go through that too is because, just like he said with arm care, a lot of the times people will go through, hey, let's go through that band circuit, let's go through that. But especially during these guys coming back for throwing, when you're going through a throwing motion, some of the highest activity is actually going to be in that forearm flexor. So that's one of the biggest dynamic stabilizers in the elbow. It's just something you can't forget about as you're going through. It's not just the rotator cuff. You can't forget about the forearm. If anything, the forearm might be more important even than the rotator cuff when we're getting these guys back.
So here, now we're at this phase, we've added intensity or weight to the opposite hand. So here, the injury is to the right arm. I'm holding it in the left hand, going through a little frontal sagittal plane, little RDL, hoping to get a little bit of a crossover effect, right? You know, research is saying that if we work out the opposite hand from an injury and we leave this one still, there's still some crossover to it. So that we're hoping to get a little bit of that.
This is a very nice detailed picture, as you can tell right here. So like what we have to do, especially during COVID last year, like a lot of you guys, you had to adapt, and we have to adapt on a daily basis. So we had to send some of our players home. And then obviously we weren't able to see them, so we had to communicate with them either through phone, through text, through video, whatever it is, but they need examples of what these exercises are. So like he said, when we're getting into this throwing preparation phase, we can start to add valgus stress into that elbow. And I think that's important because for so long we're saying, don't put valgus stress, don't put valgus stress. You need to introduce it because that's the only way that ligament or that tendon that's turning into a ligament is going to get stronger and be able to maintain the force that it needs to throw a baseball. So we also want the players to get comfortable with it too. We don't want them to think, oh, I don't want to put any stress in my elbow the whole time. I need to avoid that the whole time. So what I show here, going back, is just, this is a picture of his left arm right here. So we're biasing the left arm, and all we're doing is we're squeezing into that stick right there. And what we're doing is applying some light valgus stress into that elbow. We say early on, hey, let's go 50%, see how it feels, and then we'll go from there. We can move that up, and then we can also move the hands farther apart to get them more comfortable. Obviously, when we get the hand about right here, you move that up into more abduction, and you've got almost where they are in their throwing slot as well. So it gives you an idea of introducing that type of valgus stress safely and gives them an opportunity to get comfortable with it.
Now we're moving into weeks 12 through 22. Now we're implementing the upper body lifts, cautious, making sure that the lifts are low intensity at first. At about week 12, we want to start reintroducing the athlete into pulling. And about week 14, we'll reintroduce him to pushing. Okay. We'll begin the valgus stress 90-90, as well as we'll start working at light plyos while we're reconditioning him to play. I use the word reconditioning. We had a in-service this week, or continuing education with our department, and a guy from Philadelphia that runs a facility up there named Bill Knowles. He came down and he kind of opened my eyes, and we talked about it a lot. It made a lot of sense. He said he didn't call it the rehab process. He called it a reconditioning process. And in that reconditioning process, what you're doing is you're reconditioning that player or that athlete to get back on the field. It takes that kind of negative tone away in my head, where rehabilitation, you think, oh, there's something wrong. Whereas reconditioning, I'm just going to recondition this athlete to get back to play his sport.
So here's a plyo progression we have too. Oh, whatever, it's okay. Here's a plyo progression that we go through. These are just, we're just going to go through the two-handed plyo progression here. There's obviously a lot more plyo progression we can do, and we can transition it to one hand as well. All we're trying to do with this plyo progression is we're trying to get him to absorb and generate force. That's all we're trying to do, and get him comfortable doing something that's a little more rapid pace, because all he's been doing is going through arm care and things at a slower pace. We're trying to get him used to being in a position that's a little more athletic. And then when we move on, after we get through this phase, we're putting it overhead, because that's also something they're going to do a lot. And it just gets them used to, can I stabilize? Can I absorb and generate force at a high intensity, high pace in this position? Moving on to, we're going to bias each side. That's going to put a little extra valgus stress too into that elbow, but we want that. We want them to get comfortable getting used to generating, absorbing force in different planes of motion, especially if we're going to get them back to throwing. And then this is probably the most aggressive one. They weren't good before. We have a lot of fun, but basically what we're trying to do here is just generate as much force as we can and put that through the elbow. So obviously it's his right elbow here. That's the one that is injured. And what we're trying to do is get him comfortable putting a lot of force into the ground, into that elbow, and get him used to what he's going to be doing a lot of.
So now we've entered our last phase. Now we're beginning the throwing progression. And if you look at how long this is, it's 30 weeks. All right. It's a long time. So from a performance standpoint, what you can do is you can go back to your basic strength and conditioning, progressive overload. You can break it down into 5-week cycles with a deload, ramp it back up again. But the main thing is when that athlete leaves you as a performance coach, he needs to be stronger than he was before he injured himself, in my opinion. All right, so now we're going to continue the upper body lifts, again, progressing as needed. We're going to maintain that shoulder, scap, and elbow strengthening, and then the arm care, going back through the progressions that we've demonstrated a little bit. What we're going to show now is kind of our Scap band routine that we do with our guys. Basically here, this is the orange band, so it's pretty, the tension is pretty heavy. So obviously you want to start out with the lighter ones and work your way back up. So we can either do it bilateral, or you can go in a split stance. We play baseball on one foot, so we kind of do everything split stance or a lot of single leg stuff. So we're going to start out with a Y, and he'll go up, trying not to bend the elbows, just working the scap. Then we'll go T. Then we'll go down to an A, and then 90-90 coming in, because I know how hard that is.
Thanks for saving it for last.
You're welcome.
I think one thing when we're going through these too, you want to watch athletes. This is pretty heavy, and it probably didn't show the best form ever. But what we don't want them to do is get a lot of hyperextension here, and they're compensating through everything else. So what we say is, let's stay stacked throughout the process when we're doing it. And we might have to go to a really, really light band. That's fine. It's not a big deal. And sometimes maybe they go so much here. Let's just go one arm. Let's go one arm, and let's get used to that before we even go two. So it really depends. And
a good way to start out, obviously you can tie those to a stationary object, but one way to start out is as the medical professional or the performance specialist, you can hold that band so you can see how much strength that athlete actually has. So I want to go back and revisit, because y'all were probably going, oh my gosh, these guys are sitting here about to fight before they start talking to you. But I want to go back and revisit what the whole idea of the presentation. We got to make sure that we're all talking the same language, and we're talking about a repair, right? And that repair, anytime you have that, you have to respect that biological healing process that all of us have. And we got to make sure that we remember that my body's going to heal differently than Damon's body is going to, and we can go all the way around that everybody's body is different. So we got to make sure that we as medical professionals kind of know where that athlete is in that process, and because he's going to be stuck, he's going to be immobilized for a long time. There's going to be strength loss, there's going to be atrophy, there's going to be a limited range of motion. But most importantly, like we tried to show you guys kind of in a comical way, you got to be on the same page. You have to be able to collaborate. You have to be able to say, hey, Merritt, I don't understand what it is that you want me to do. I check my ego at the door, and I am open to whatever suggestion he has. And I can't speak for him, but I've worked with him long enough to know that it's a two-way street. My ideas are just as good as his, even though he's the medical professional and I'm the performance coach. That collaborative effort that we put in is what makes our team completely unique and completely different than all those around.
Going off of that point too, it's a lot of communication between us, and then at the same time, we can't forget about that athlete too. It's a collaborative approach between all of us. And in that process, we got 30 weeks where, hey, you're starting to throw. We're going to spend a lot of time trying to get you ready. Like he said, it's reconditioning. It's not rehab anymore. How are we getting you ready to be the best player you can be? And it's not just collaborative effort between me, Dave, and that player. We also have dietitians. We also have pitching coaches. We have other people that we want to get everyone involved in. We're working on a lot of things in the process to do what's best for that player and put him in the best situation to succeed, because the last thing we want is to have him here. A lot of these guys are really fun to work with, but I don't want to deal with them for longer than I need to. Once they leave us, I want them to leave us and never come back. That's usually what I say.
Thank you guys very much. Our emails are down there at the bottom. If there's anything that we can ever help you with, or you have a question or anything moving forward, we're always looking for people to come in and be interns with us. So if there's anybody that's interested in anything that, we'd love to talk to you about that further. We're always looking for, like we showed our mission and values there, and we're always looking for those that share the same mindset that we do. Thank you guys again.
Showed like the internal brace versus the reconstruction, and how you got to the throwing progression at 10 weeks versus 24. When you actually get to the throwing progression, is it any different in those two, or once you get to that point, is it the same throwing progression?
It'll probably depend, but for us, for example, we'd use the same throwing progression because we have that time. We're going to use that. Also, So internal brace is newer. So one of the examples we had this year was a guy who his internal brace was actually a revision. So because of that, we were a little more cautious because this is the second time going through the process. So to play it safe, we made it as slow as the Tommy John rehab because we didn't want to push things too much, only for him to go through a third surgery on that elbow. So it's really going to depend on the situation. But for our situation, we would probably have the same throwing program because that's kind of we've done a lot of throwing programs, and so we want to do what's best for the athlete and work on what's the easiest way to progress them safely.
And the beauty of what we do, right? We can progress and regress when needed. It's not a race.
So actually, I was going to ask about what like the re-rupture rate was for like UCL and stuff, because I know like I do a lot more like lower body, so I always talk like UCL. We want to prevent like any second ACL, third ACL, other leg, other. I mean, for baseball, obviously, you don't have to worry about the other arm, but what is the rate on that? Because you did say you had a second one.
Yeah.
You can repeat the question, that would be great.
Yeah. Sorry. So the question was, what is the re-rupture rate for UCL, especially since a lot of people work with lower extremity, and there's a lot more research on ACL re-rupture rates. UCL re-rupture rate is not very high. I can't say, I'd say maybe 5%, 5 to 10%. So it's a little more, you feel more confident going through it, but nothing is ever set in stone, and every player is so different that, you can't guarantee. And also, we don't know sometimes what they're doing in the off season, and sometimes they might not be doing the best thing for them, but all we can do is kind of work with them through the process. But the rate isn't as high, but it is out there.
In that same thread, can you talk about when you take a look at a UCL injury on an image and you decide that a conservative, because it's proximal rather than distal, a conservative approach is better? Can you talk about failure rates in a conservative approach?
Conservative, not having just
Just letting the body do its thing and kind of start down.
Yeah, that's actually a really good question. So talking about the conservative approach, proximal versus distal tearing is actually something that's pretty interesting too. So how the UCL ligament, the anatomy of it, if it's where it is distally, if there is a distal tear, 9.5 times out of 10, that's going to be a reconstruction most of the time, because where that tear is and the line of force on that ligament right there, you're going to have to repair that because it's not really going to heal. It's not going to heal, and there's just so much stress and strain going into that. When it's a proximal tear, a lot of the times you can be, I guess, if you're going to have a tear, you hope for a proximal tear if you're going to have anything, because you can be a little more conservative. Conservative approach, though, is pretty hard. I will say we've tried it, and we have a pretty good success rate, but it's a lot less than UCL. But if we're able to get guys back without surgery in 3.5 to 4 months, we'll take that chance sometimes.
I have a question on kind of modalities you guys use and how they might vary throughout each phase.
Yeah, we early on we do a lot of different swelling modalities. So it's like Hivamat, if you've heard of that. We use one called PEMF, which is pulsed electromagnetic field. And so it's one of those things that a lot of it early on, all we're trying to do is deal with swelling. And then from there, we have laser too to help with scar healing too. And then our plan though, and what we want to do is get them out of modality town. We don't want them getting in the habit of constantly doing modalities. And sometimes they get so comfortable with it because you don't have to do anything during a modality. You sit there and everyone's doing whatever for you. But sometimes we have to take a guy and we're like, hey, you're good now. Let's get off of this. Let's start doing some active stuff. So yes, we need it early on because, like Dave said in the beginning, we need to respect biological healing and we need to help the body heal and promote healing. But we also don't want them to get stuck doing that for 10, 12, 14 weeks.
Do you guys use BFR for upper extremity?
Yeah, so we use BFR too. Same thing right there. This is more something we've talked about. I don't have a good answer, and I'd honestly be curious for anyone else here even. We wait until the stitches are out. It's mostly just honestly play it safe for the hypothetical chance that all the blood flow that's stuck there, a stitch might pop or something like that. I don't know if anyone's had experience using it without or with the stitches still in. I'd be curious if anyone has here, but that's usually what we do with it.
Criteria you guys use to progress phases outside of time?
Yeah, sorry. He asked what other criteria we use outside of phases to progress things. So I think we wanted to put together progressions just because it was an easy way to go off of time and guidelines. None of these times are set in stone with any of that. So I think it's easier to see it that way, and it's easier to prepare and put it together. But a lot of the times it's a lot of strength and a lot of functional mobility that they have and functional strength that they have. And then combined with introducing some type of plyometric or something that is going to transition to what they're doing as an athlete more. Something that I thought was pretty interesting and fun that we started doing this year more was collaborating a lot with our pitching coaches. And so getting to collaborate with them, we went through a lot of the mechanics rabbit holes and kind of learned a little bit more about how do we put our players in the best position as they're throwing so that when they get on a mound finally, they're in the best position to compete and succeed too. So there's a lot of different factors. We look at range of motion of everything, not just the elbow and shoulder, hips, ankles, everything like that. And then it's a lot of different factors that all come into how we progress, guys.
That goes the same for the weight room also.
I have another question on, I know we're talking about pro athletes, but I just want to like scale back and pretend I have a high school athlete that had UCL and like real world, they have 30 PT visits. Like, where would you focus your rehab? Because that's like real life. I know that's not what you guys deal with, but like, if someone, same thing with like ACL, it's like, how do you take someone through like a 6-7 month rehab? And let's say they literally are so limited and this is a big undertaking. How do you focus on all these different parts of the healing process and rehab when you are so limited in what you can do with that?
So the question was, how do we do this type of rehab at a clinic compared to, obviously we have a lot more resources than a lot of clinics will have. I think it's actually more similar than you would think, because once we get them, I mean, honestly, our goal is to make them as independent as they possibly can. The last thing we want to do is have, like, we have one of our athletic trainers here right now. The last thing we want to do is when that player's at the affiliate, he has to rely on the athletic trainer for everything he does. Our goal from the start, once they get to a point and they don't have any limitations and range of motion, is how do we make you as independent as we can? And how do we make the program cater to what you want to do? So a lot of it's making them as independent as they can so that they can continue to be baseball players. And honestly, when the more independent they are, the less they think about that elbow. They think about, how do I keep performing and how do I get better, get stronger, and go from there.
The question here, more geared toward Dave.
Hey,
How do you feel about the throwing athlete, the overhead athlete, and bench press?
who wrote that? No, I'm just kidding. No, do I have to repeat that question too, or is they can hear it? How do I feel about the overhead athlete and bench press? I'm gonna say straight bar bench press. I'm 100% against it. Dumbbell bench press with a scap off the side of the bench, one arm or two arm on the other side. I think it's good because I want that scap to be able to move freely. I don't want to pin because everybody that's ever knows anything about weightlifting, when you're bench pressing, you pin your scaps to the back, you lock everything in, and now you just drive it up. Me, in my personal life, I like to bench press, but as far as training my athletes and what is best for them, I kind of disagree with it. However, I will say this, I don't encourage it. But there are guys that come from universities where that is a staple in their program. And my job as a performance coach is to get that athlete to see that, maybe that's not the safest way. Because we do get guys from that have different training ages. We had a couple guys that just came through that we just drafted that had never worked out in their life, coming from places where it just wasn't important. And then you have guys that come from SEC programs where, they're Olympic lifting and bench pressing all the time. And so my challenge for me is to be able to convey to him, or not necessarily sway his opinion, but show him the benefits in not doing that type of lifting, because of the increased risk for injury, and try to get him into some other way to get the same adaptation that you get from a bench press in a more safe manner. Whew. That's the question everybody always asks.
It's a good question.
Thank you for your time and everything in coming here, sharing with your experience with us. I believe that is a critical pearl, and that you guys sharing the critical pearls with us, it really drives our industry, sports medicine, to the better place. So,
Thank you.
Thank you.
I am making some presentation for UCL actually at this point. So I started interviewing a few people among NLP organization, doctors and stuff. And I learned the last several years that protocol kind of guideline has been changed quite a bit, which is awesome because now we know we are advancing. So with that being said, I have lots of questions, but I'm limited too. Weighted ball integration. Do you guys utilize that? And second, that is my burning question. When the client going back to sports participation, actually return to sports, the very last part, when they are doing bullpen stuff, they feel great. How was the bullpen go? Awesome. We checked the velocity, 85. That last part of that, if we wait too long before they go back to the game, in adrenaline in the game, they may be able to, but maybe ligament is not ready for it. So if you have any tips,
I'll start with the first question with weighted balls. It's a really good question. And I think I would almost counter that with kind of what are you using weighted balls for? Because how we use it is very different than how I think a lot of other people use it. And that's going into what we were talking about when we work with pitching coaches. So we use weighted balls. It's not really velocity based whatsoever. We're not trying to, hey, let's use that ball and throw it as hard as we can or pull down into the wall kind of thing. We use it more for mechanic based, and we're trying to work specifically on certain parts of the mechanics. What can we do? How do we get hip shoulder separation better? How do we work on at least rotating through our trunk and not getting as much into our elbow? So one way I think about it too is if you grab something really, really heavy, your body is not going to allow you to throw that thing all out here like this. You have to clean up something outside of this to get that ball going forward. So I think we use weighted balls more for mechanic based, and then it really depends on the guy and how we use that. Some guys, it might be they can't really get into that back hip. So what we're going to do is focus on some things where they sit in and then they throw a ball that way. So they get used to mechanics through that, but it really depends. We like weighted balls, but we use it in a different way, and it's not ever really velocity driven, it's mechanic driven. So I would say that's the answer to that.
I'll take the second one.
Yeah.
From my perspective,
I'll repeat the question too.
Oh. So how do you, and I'm probably butchering this up, how do you prevent an athlete who is coming off of Tommy John surgery and is throwing a bullpen? How do you limit the drop in velo? Is that close?
or they are trying their best, but velocity is not there. It's not quick.
Okay. They're trying their best, but the velocity is not there. Okay. For me, I think it goes from the very beginning of the program. The program has to be holistic. All right. And I think that each part has to fit together like a puzzle. So you don't lose the strength, right? You do keep the movement pattern of throwing. The throwing mechanics are worked on in our room, in the weight room at Salt River Fields all the time. Like that is like the bridge that goes from my weight room. So it's the way it's the weight room, the agility field, the baseball field's right on the other side. So when those guys leave that weight room, they go out there and they do that throwing mechanics, and they have doing aqua balls and stability exercises that gets them in the proper positions. I think personally that if all those puzzle pieces are together, that when that athlete gets out there and throws that bullpen, maybe the first couple might not be what he's used to throwing, but it's our job to come together and collaborate and say, all right, what did we miss? All right, well, hey, let's implement this. Let's get with our skill acquisition guy and figure out what is going on here. What's the pitching coach see with his mechanics? See, I don't think that our job ends as soon as that guy goes out there and throws his first bullpen and say it's not 98, it's 92. All right, well, let's go back and let's reevaluate what we've done and what can we add to from a skill acquisition point of view, or what can I do in the weight room to progress his load even further to get him in the positions that he needs. Does that help? It's kind of where my head is with it.
And just tempering expectations there. I'm not expecting a guy. It depends on every single guy is so different. You might have guys who immediately are throwing the same speed, if not harder. Some guys that might not be there and they just need more reps. And sometimes you got to put them in a game to see how it goes and give them the reps there, because that's where the adrenaline is going to kick in too.
And it's a mental thing too, right? I mean, I can tell you from experience, when you get to that, you start getting scared, oh, am I going to blow out again? I had a weightlifting injury 2 years ago, and I'm lifting more weight than I did then now, but it didn't just happen in a couple of days because I was worried, oh my gosh, am I going to blow out again? So I think there's an element of that too, especially when they look at that TrackMan and things are off. So now the mental skills people got to come in and they've got to get going. And, we kind of throw that mental skills around a lot. We're all mental skills coaches. I know professional sports has that actual department now, but we're all mental skills coaches.
There's going to be another extensive question, probably could warrant its own talk, but tell me about your opinions on treating internal rotation deficits and how you monitor relative strength in the arm and its relation to how it affects pitchers, not just coming off of rehab, but also in their say a starter going through his 25th start.
Trying to think about where to start with that question.
Yeah, it's a great question, or multiple great questions.
Yeah, I think you're going to lose. There's a lot of ways. A lot of time when you're throwing, you're going to lose internal rotation. All we can do is try and continue to get back what's normal for them. I think everyone is so different. We're not trying to get someone who's normally 50, 60 degrees and have to force him to get 90 degrees, because that's just not who he is. That's not how he's built. We're not trying to give him too much if that's how his body is set up to be. We want to get him exactly what his max we can get out of him. But I mean, when you go throughout a season's a grind in general. Like things are going to happen. They might have that. They're going to lose strength along the way. There's a lot of different factors. Our goal is to maintain that as much as we can throughout a season right there. And I think one thing that we didn't really get into, but is important throughout a season, is we want to have the heavy days heavy and the light days light. So when they pitch, well, the arm care that we went through, some form of that, they're going to do the days that they throw. And then the light days, when the day after that, that's the recovery day. It's, hey, let that arm rest. You get a recovery day, because when you're going through a season, you're not going to get many of those. So let's make sure that we stack, or at least have as many recovery days as we can in that week, so that they can recover and then perform in their 25th, 26th, 27th start.
And it's mandatory for us that on the days that those guys pitch, they have their arm care, sure, but they also have the upper body lift. And then they have the option of doing a total body lift that night or getting their lower body in the next day. But I think this might answer the rest of that. I had a very successful retired now major league player tell me, World Series champion a couple times. He told me that his job every single year, this is great advice, his job every single year as a player was to come into spring training at a 10, whatever that 10 looks like for him. And because no matter what he does, no matter what I do as a strength and performance guy, he's going to be a 7 in October. So my job is to come in at a 10. I'm going to lose 3 because I was like, where do I fit in all that? And it's not necessarily a maintain, because I don't really like that, because I'm going to be different from a strength point today as I will be tomorrow. I didn't lift today. I lifted yesterday. Me personally, I lifted yesterday. I didn't lift today. I'm not going to lift tomorrow. Monday, I'm going to be pretty strong again, but I need those recovery days. Whereas he comes in at a 10, he loses 3. Well, in the middle of that, I got to do what he needs for that day and whatever that is. And, you don't want to force a round peg into a square hole. So with the limited rotation, I'm not going to push that down. He's going to throw where he throws.
Going off of that even more too, like we're going to also maintain, like we want them to maintain the IR that they have, also horizontal abduction, because when they're falling through, we don't want them to cut themselves off there. But baseball is not a normal motion. we're not meant to throw a baseball. So for us to expect that we're going to feel 100% when we're throwing a baseball for 3 months straight, it's just not going to happen. And like, I mean, I threw a lot this year with guys and my shoulder was killing me sometimes. My elbow was killing me. And it's just like, that's normal. That's what it's going to be like. So we can't expect and have these false expectations that throwing a baseball for 6 months straight is normal. And I'm going to feel 100% from day 1 to day 180.
And Merritt doesn't throw 100 miles an hour.
I don't know. Yeah.
Kind of spit off the defense question. When in reconditioning are you guys, or maybe more return to play, are you guys okay with the weighted ball routine starting to be implemented?
It's a really good question. And it's something we actually have worked on this year of trying to find the best time. What we're starting to do is let them throw a little first because, hey, let's not think about anything. Just throw a baseball again. Throw a baseball again. We'll have them do other type of mechanical things that don't involve throwing, but putting another weighted ball and having them focus on all this when we need to get them back throwing, that's the most important thing, is throwing a baseball early on. And then with that too, let's say we have him do that and he's doing weighted balls and something else at the same time. What if the next day his arm is absolutely killing him right there? Do we know it's the throwing the baseball? Was it throwing this weighted ball? Maybe he wasn't doing the best job with this, or this one. So it leaves a lot less variables when it's focused on throwing a baseball and lower body mechanics. Once we get a feel of that for a few weeks, let's start doing some more mechanical things because they're going to be throwing a long time. We don't need to rush into it just to get them started 2 weeks earlier.
Yeah, we use the PRI assessment, and all of our guys go through that in spring training in a normal year. This year we had to do it at the affiliates, and then we just keep it. And if there's any red flags, then we'll base their program off of that. But other than that, we really don't refer to that unless there's something that ends up happening, which we hope nothing does.
We'll keep track of their range of motion measurements in case something comes up too. And then it's always like, if a guy's going up to throwing a game that day, it's something, if we're just doing some type of warm up, arm care, whatever it is, it's an assessment too. We're not just having them, they might think they're just doing their normal routine, but we're also assessing them every day that they're going out to do something like that. I had another part, I can't remember what I was going to say, but yeah.
You don't see these too often, but do you know if there's a different protocol for a posterior bundle tear rather than an anterior?
Not that I know of. Usually they just do repair if it's an anterior bundle. I haven't seen any time that we've had a posterior bundle or have worried too much about the posterior bundle that I'm aware of, at least.
I have no idea.
You touched on it a little bit, PRI. I'm just curious, and this can be kind of in general, doesn't have to be a PCL athlete, but where do you, I know you guys use PRI a lot on the PT side, so I'm just curious of where you maybe implement some PRI strength conditioning exercises on your guys' end, or don't worry about it.
Yeah, we do a lot of the correctives in the weight room as part of their warm up. So the 90-90 hip lift, the hammy march, all that stuff is pretty routine for a lot of our guys from the bottom all the way up to the top. So the corrective is probably the main part that I use. And the ATs also, they use a lot of it when they have guys come in and see them. They use it to get them kind of, we want to get as much stacked as we can, right? We don't want to get that pelvis in a neutral position, which we can argue all day long that we'll never get it, but that's optimal, right? So we can work toward that, and that's kind of the goal. And if it makes a guy feel good, man, I want that guy to do it because I want him to go out on that baseball field and mash. Awesome. Thank you,
Cool.
guys.
Sweet. Appreciate it.